I'd like to discuss with you an important topic, I think, in the survivorship or in the operative results of our patients. That this is thromboembolic complications. So this is my first question. Bladder cancer patients that are at high risk for thromboembolic events, specifically, 1, when treated with neoadjuvant cisplatin-based chemotherapy, 2, when treated with primary cisplatin-based chemotherapy for metastatic disease during the first week of post-radical cystectomy and after discharge from post-radical cystectomy. And all of the above. All right, you got it. You got it right. Next. Most thromboembolic events that occurred after radical cystectomy occur within a week of the operation, occur after discharge home, are symptomatic or associated with 15% mortality. Okay. All right. We'll talk about it. Next, or we have a next one? Okay. VT prophylaxis in bladder cancer patients is currently indicated. Post-radical cystectomy during the period of in-hospital stay and limited mobilization. B, for a period of 28 days post-radical cystectomy. C, during cisplatin-based chemotherapy in ambulating patients. And for all patients with advanced bladder cancer and pelvic lymphadenopathy. All right, so majority knew the answer. All right, so urothelial carcinoma is a very thrombogenic tumor, and there are many reasons for that. First of all, it's a very hypercoagulable malignancy, and this is just because of some biological properties. The tumor can express tissue factor and overexpression of heparanase, which are actually coagulable factors. And interestingly enough, and we'll touch on that, are also factors that promote invasiveness and metastatic disease. And there is a correlation between patients who develop thromboembolic events and patients with advanced and worse prognostic factors. There are patient-related factors. Patients are usually old. Smoking and obesity, all of those are risk factors for VTEs. Treatment-related factors, obviously pelvic surgery with extended pelvic lymph node dissection. This is a significant risk factor. And systemic chemotherapy, in particular cisplatin, which is a thrombogenic agent, and we are going to talk about that. And there is also increased detection of incidental BEs because we do a lot of cross-sectional imaging around the trajectories of the patient's disease and treatment. Tissue factor is expressed on cancer cells as well as on cancer cells derived microparticles. And cancer also induces inflammation that can further increase the tissue factor expression in host inflammatory cells that are within the tumor. We know that now. The tissue factor, localized coagulation factor 7 to the cell surface of the activated clotting cascade. There is overexpression of heparanase, which has been shown to be more common in patients with high-grade disease and locally advanced and metastatic bladder tumor. And this heparanase degrades the extracellular matrix and has procoagulant effects. So this is from the biological standpoint. And VTE complications in bladder cancer patients, if you will, can be in 3 major trajectories. The most one that we know is post-radical cystectomy, but we have published recently, and we had our focus on the neoadjuvant chemotherapy population, and we'll talk about that, and as well with patients with metastatic bladder cancer getting cisplatin-based chemotherapy and other chemotherapy. It's very important to know that it's not only venous thromboembolism, it's also arterial thromboembolism that can occur in this setting of malignancy, and we tend to forget that, and this is very important because they are very, very dangerous. And they can be, such as in myocardial infarction, we know that, and ischemic stroke. Now, if you look at the post-radical cystectomy, this is a data that was derived from the NSCIP database with about 44,000 patients with 11 types of malignancy and their associated cancers. And you can see that if you look at the 30 days incidence of DVT, cystectomy is actually just secondary to esophagectomy, very high incidence of about 3%. If you look at PE, it's even higher than esophagectomy. Number 1 in terms of malignancies, in terms of PE development within a the 30 days of radical cystectomy. And if you look at all VTE, again, 5%, and that is just secondary to esophagectomy. So bladder cancer and radical cystectomy for bladder cancer are very thrombogenic. What's interesting is that now there are new guidelines or be guidelines, at least in Europe, and they estimate the risk of VTE to be up to 11.6% among high-risk patients. And high risk, they would define it as prior VTE or any combination of 2 or more of the risk factors, respectively. And the risk from bleeding in this, covering these patients is very, very low. And these are the risk factors. So high risk is prior VTE, patients with any combinations of the 2 of the one on the medium risk, which means age of more than 75, many of our patients, high BMI index. And we know that this is very important to cover them. This was put up by Gordon Guide from McMaster University. And that, I think, I don't know how much in North America, but does lead a lot of the VTE protocols now, VTE prophylaxis protocol in Europe at least. VTE in radical cystectomy, the majority of patients that undergoing radical cystectomy fall either into moderate, which is about 3 to 6% event, or high risk of VTE, which is about 11%, as we saw, according to the American College of Chest Physician clinical practice guidelines. The risk of significant bleeding from VTE prophylaxis in this patient population is very low. So what is the optimal duration for pharmacologic VTE prophylaxis after radical cystectomy? And we all realize that we have to do that. So this is data from Teresa Kupi, who looked actually at the end-skip data, particularly for radical cystectomy. So she had about 1,300 patients who underwent radical cystectomy. She found, again, 6% overall incidence of VTE, the same percentage we saw from overall. Median follow-up time to VTE was in 14 days. And in fact, 55% or the majority of VTEs were detected after discharge. And the mortality, if you do have VTE, or if you did have VTE, was very high, was 6.4%, 30-day mortality if you were diagnosed with VTE. This is just a graphic presentation for that. So message number 1, most or majority of VTEs post-radical cystectomy occur actually after discharge, okay, when the patient is not anymore under our care. So the Enoxacan 2 trial was a pivotal trial that addressed the question of VTE, the duration of VTE prophylaxis in patients who undergo abdominal or pelvic surgeries for cancer. And this was a double-blind, randomized, multicenter trial that was done in a population that were planned to have open surgery for abdominal or pelvic malignancy, not urological specific, although about 10% of them were urological patients. They were divided between enoxaparin, which is a low molecular weight heparin, 40 milligrams subcutaneous daily for about 28 days there, or just at the time of the hospitalization. And the primary endpoint was actually radiographic, which is a bit of a caveat of this study. Nevertheless, one could see that there was significant therapeutic advantage for 28 days of VTE prophylaxis with enoxaparin that translated to a significant decrease in the event of VTEs along the 28 days, and it did not translate to higher or significant higher bleeding, either any bleeding or major bleeding. So this turned to be kind of a guidelines for or a recommendation for extended prophylaxis in the for abdominal pelvic surgery, cancer surgery, but it hasn't been percolated into urology practice. And then came this paper by Gary Steinberg from the University of Washington, and they actually looked back at their series. They adopted the 28 days of VTE prophylaxis in January of 2013. So they looked at the event rate before that and after that. And what they could show that in a total of 400 patients, they could see that the overall VTE event decreased from 12% to 5% with the extended prophylaxis regimen. And the principal benefit was actually post-discharge VTE rates from 6% to 2%, which was clinically significant. And again, about half of their patients had their VTE event after discharge. So this is very, very important to recall for the practicing clinician here. there was no increased risk of bleeding in the extended prophylaxis. So patients with bladder cancer who undergo radical cystectomy, VTE occurs with significant frequency. It's about 6% if you look at many series. Some of them quotes more than that. VTE associated with morbidity, cost, and mortality, and can be favorably modified through employment of extended low molecular weight prophylaxis for 28 days. The question is, should the extended VTE prophylaxis be longer than 4 weeks post-radical cystectomy? There is actually interesting data from Ontario that about 1.8% of VTE were diagnosed even after 30 days, between 30 and 90 days from surgery, and 10% of the patients who developed VTE within 90 days of surgery, 1/3 were diagnosed between day 31 and 90. What we showed in our study on patients with who undergo neoadjuvant chemotherapy followed by radical cystectomy was that about 5% rate of late thromboembolic events, so more than 30 days. So even though we cover, and the guidelines are going for 28 days, this is the American Chest, the ACP guidelines, still after 30 days we could see thromboembolic events. Now, we had an interest shifting into the neoadjuvant in seeing how the effect of cisplatin-based neoadjuvant chemotherapy affect the occurrence of a thromboembolic event. So we first look at our institution at 202 patients, and we did show that there was enormous amount of patients, about 90%, who had VTE either at the time of the neoadjuvant chemotherapy or after the surgery. And this was compared to about 5.6% to patients who went upfront to a radical cystectomy, obviously matched by tumor characteristics. So we were quite puzzled by that, and we embarked in a led international group, and Peter Black here contributed much to that as well. And we looked at multiple institutions to see if that's indeed the case. And we had these institutions from Europe, the US and Canada, to overall of more than 800 patients. We did look also at the Corona score. This is a score that classified patients who undergo chemotherapy to the risk of thromboembolic events. And that that relates to mainly to the site of malignancy, with bladder being a high risk and getting 1 point score, and BMI, as well as some CBC variant, and I don't have time to go over that, though. I'll skip that for the interest of time. But what we could show is that, again, across the study, there was about 14% rate of VTE, so not that far from our 90%. Here we marked it by the center. Interestingly enough, preoperative VTE occurred in about 7% of the patients. So that's during the time of their neoadjuvant chemotherapy. What you could see here is actually that there was a variation between the institutions. And we actually related that, or we hypothesized this relates to the post-neoadjuvant chemotherapy imaging practice, because not all centers at that time at least did a CT of the chest. They did CT abdomen pelvis, but not CT of the chest. And this is very important. I hope you will capture this message, because I think it's also very, very important. So we could find incidental PEs in staging CT, okay, that was done after the neoadjuvant chemotherapy just before the surgery. So you may say, well, it's incidental, patients are asymptomatic, but the literature, the thrombo literature, would indicate or would suggest that these incidental PEs, which can be detected up to 11% of patients who undergo chemotherapy and chest imaging after that, have the same impact on survival and complication compared to symptomatic VTE. So those are very, very important. And I think including a CT of the chest not only would help you in terms of staging, but I think if you detect these incidental PEs, you do a service to the patient. And if you can see, if we divide it again, so this was developing of TEE, or thromboembolic events, post-early. So this was about 2.6% in this patient population, and late about 5%. So that potentially suggests, and we didn't continue on with studies on that, that you may need to give for patients who undergo neoadjuvant chemotherapy followed by radical cystectomy even a longer period of VTE prophylaxis. Types of VTEs, it was divided between DVTs and PEs, although, as I mentioned, there were arterial events and speaking to people. Some people had, not in this series, but speaking to people after that when we presented the data, had, for example, mesenteric emboli or even a limb emboli. Again, about a third of the PTEs in our patient population were incidental. Interestingly enough, it seemed to be separating the curve of survival. So if you did have a VTE event, you had worse survival. And that may correspond with the fact that tumors that are thrombogenic and secrete tissue factors and heparinases that are also associated with degradation of the extracellular matrix and development of metastases share the same profile. So in conclusion here, thromboembolic events were common, very common in bladder cancer patients who underwent neoadjuvant cisplatin-based chemotherapy. The majority, and this is another lesson to recall, here occurred before the radical cystectomy. So about 58% of the VTEs in this patient population occurs even before the cystectomy. We demonstrated that thromboembolic events is an independent predictor for progression-free survival, that's about that. So now, how about patients that undergo chemotherapy for a metastatic disease? So not in a neoadjuvant setting. Well, there was this excellent systemic review by the group of Brandt-Einman, and this was a systemic review and meta-analysis of 62 studies, about 5,000 patients, and in this patient population, this is all around the world, there were about 373 VTE events, and the rate is about 4.5% event rate on patients that are undergoing chemotherapy for bladder cancer. Now, as you can see, there is a lot of heterogeneity. And this is very interesting because when they looked at the origin of the studies, they could see that North American studies or American population had about 7% VTE events compared to Western non-North American with about 3.2% and less than that in non-Western countries. So that may relate to different practices in VTE prophylaxis, different types of imaging, or different patient characteristics. Interestingly enough, they looked at all types of chemotherapy that were delivered to patients, and one may want to recall that anti-angiogenic, such as bevacizumab, had up to 20% event rate. Very, very important. Interestingly enough, MVAC had about 5%, where GemCit has about 6%. Another thing that was very interesting, that prior radiation increased the risk of VTE. So, for example, if you have a bladder preservation and then you get chemotherapy, you still have a high risk of VTE despite the fact that you didn't go a radical cystectomy. Lastly, another, I think, interesting paper. This is a multi-center retrospective international study of about 29 academic institutions, and they could show that there is a cumulative incidence of VTE of about 10% in patients who are treated with chemotherapy, and the risk factors that they could identify were non-urothelial histology, so variant histology, if you will, renal dysfunction, and cardiovascular disease. So this brings me to the end of the talk, which I'd like to ask with you, should we apply thromboembolic prevention during chemotherapy in bladder cancer patients? So the risk is so high, should we do that? So essentially, there are no trials that did ask this question and try to answer that in the bladder cancer patient population. But there was a trial, the SAVE-ONCO trial, which was a randomized, double-blind clinical trial of about 3,200 patients with locally advanced or metastatic solid organ malignancy, so not necessarily bladder cancer. And they could show that there was a 64% reduction in the incidence of symptomatic VTEs when they used when they used oral anticoagulants, semulaparin. That was very, very impressive. However, the problem was that the incidence of VTEs in the placebo group was about 3.4%, and the reduction, the absolute risk reduction was about 2% only. And based on that, the FDA did not approve this prevention strategy in ambulatory cancer patients who undergo, with solid tumors that undergo chemotherapy. So the current guidelines by the ACCP, so the American Chest Society in ASCO, recommending against routine prophylaxis in ambulatory patients with cancer receiving chemotherapy, with the exceptions of those with high risk factors, for example, previous VTE, immobilization, hormonal therapy, this androgenic inhibitor therapy, and thalidomide. But I would argue, and I would like to leave you with that I still think that there is a rationale to run a preventive study in patients with bladder cancer. And the reason is that if you look at bladder cancer, the risk is very, very high, way higher than the 3.4% that was in the baseline risk of the patients in this in the SAVE-ONCO trial. So I do argue that potentially, if we do apply a prevention strategy, particularly in patients who undergo a neoadjuvant chemotherapy, where they have a basis of about 14-15% chance of having VTE, that we'll see a higher absolute risk reduction. Perhaps that will be towards the benefit of our patients. Thank you.